This is a initiative from the residents of the Palliative Care University at La Savannah University. Our goal or our motive to be here is to talk to experts in different fields about cutting edge papers and cutting edge research that can help us become better physicians. Today we have the pleasure to hear Margaret Campbell. She's, well, super known in the palliative care scene because her studies on dyspnea in different settings, validating scales, and her last work that I think is one of the milestones of research that has been done in the, I don't know, maybe last 5 years, 10 years, is this algorithm to do a correct extubation at the end of life. But the idea is to hear from her, so I won't talk too much. I just want to acknowledge that we on the call also have Jessica McFarlane, who is an expert in neuropalliative care, and she's also joining us today as a co-host to help us out understanding what Margaret is going to share with us. So Margaret, please go ahead and take the scene.
All right, thank you very much. That was a very nice introduction. So this study was completed almost 2 years ago, and it's the effectiveness of an algorithmic approach to ventilator withdrawal at the end of life. And this is the culmination of 30 years of my research. Let's see, page down, next page, come on. Why aren't we advancing? Okay, we've got the slides up.
Don't worry, there
we go. Okay, so as many of you know, the commonly employed methods are two. One is where the ventilator is turned off as a single step and the patient is extubated, sometimes referred to as a terminal extubation. Another method is terminal weaning, where there's a staggered reduction in oxygen and ventilation with subsequent extubation in most cases. The gaps in the evidence that I attempted to address in this trial was, can distress be objectively measured? Who needs pre-medication, assuming that it's not all patients undergoing this process? What doses of which medications constitute safe and effective care? And can I do a comparison of rapid weaning to immediate extubation? As I developed this algorithm, it was giving consideration to the fact that one size was not, or one approach is not suitable for all patients. Yet, what we know from previous descriptive studies is critical care units tend to use one or the other method, or one method is chosen whenever a particular physician is the attending, because that's what that physician is preferring to do. But instead, I took an algorithmic approach that the approach should vary based on the patient. So while we have some occasional patients who are awake and aware, these are also the patients at the highest risk of respiratory distress, and also the patients who are likely to tell us when they're having difficulty breathing. These do not constitute the majority of patients, however. These patients might be homebound patients, or they might be in a long-term acute care facility or a long-term care facility. The two most common populations that undergo this process are the cognitively impaired and the unconscious patient, who are able to or may be able to experience distress, but both of these populations are unable to give us a dyspnea self-report. And then the last group that have not been included in most studies, although occasionally in some of the early studies back in the 90s, brain dead patients were included in the descriptors. And these patients are completely unable to experience distress. So what I postulated is needed is a patient-centered evidence-based approach, and I chose an algorithm rather than a protocol. A protocol typically follows the same steps for each patient. For example, the way we place a central line is done the same way across patients. An algorithm, on the other hand, allows us to standardize, but has decision trees that let us capture the unique needs of the individual patient. And further, we need an objective measure of distress, since most patients cannot tell us. And so that's where this algorithm relies on the respiratory distress observation scale. It was funded by the National Institute of Health, National Institute of Nursing Research, and the study was conducted between these years. There was a suspension of the study for 2 years, secondary to the pandemic. I was not allowed to put my research assistants into critical care units because of the risk of COVID. Hypotheses were that patients in the algorithm arm will be more comfortable compared to the control arm, and that there would be differences in medication administered. We could generate these hypotheses based on a pilot study that we completed in 2015. The algorithm has a number of decision trees. The first is whether or not we pre-medicate, and that's if patients are able to experience distress. And we use the Richmond Agitation Sedation Scale because it's commonly used. So the patient who can experience distress at a RASS +3 to ±3, or the patient at baseline is in respiratory distress with an RDOS score greater than 3. Otherwise, pre-medication is not indicated. We employ a rapid wean if the patient is able to experience distress, but an immediate cessation if no responsiveness. So we use the RASS -4 or -5 to signify those patients. During a wean, we pause the wean at each incremental staggered reduction of oxygen and ventilation whenever the RDOS score is greater than 3, so that there can be a bolus with morphine or fentanyl. Then the ventilator is discontinued and nearly every patient is extubated. There are occasional unique circumstances where perhaps the tube is left in place. At the end of the process, we consider the need for continuous morphine. Rather than starting it at the beginning and grabbing a dose out of the air, we wait until the end and we look at the expected duration of survival and or did the patient need morphine during withdrawal. So if the patient remained comfortable without, then there isn't an indication for a drip at the end. The respiratory distress observation scale. 8 variables, each scored 0, 1, or 2 points, and then the points are summed. This scale has been translated into, I believe, 8 languages now. So if there is an international audience listening to this, there's a likelihood that there is a study-specific, culturally specific scale translation available to you. We did a cut points examination of the RDOS and found these cut points. And for this trial, we used mild to no distress as our comfort goal. It's not realistic to say no distress in the context of breathing failure, hence our use of mild as the cut point. So our participant characteristics, you see that we did have an uneven group because of pandemic suspension. Our control arm had more patients than the intervention arm. We used a step wedge cluster randomized trial. So all 5 of the study sites began the study in usual care. And then at a random assignment, one site at a time crossed over to using the intervention as the unit standard of care. So in spite of the uneven groups, you see that the groups are fairly well matched with regard to age, gender, ethnicity, illness severity, and baseline oxygen FiO2 ratio. All patients in the usual care received a 1-step terminal extubation. And this surprised me because I had 5 different unique intensive care units, yet none of them were using weaning as their default approach. There was high variability in usual care in which medications were used by both drug class and dosing, and they were using no standard measure of respiratory distress while in usual care. Once the patients were enrolled in the intervention arm, 58% of them were weaned as the decision tree predicted for them. Only morphine or fentanyl were administered for distress, and RDOS guided medication use. These are the major results, and I wish I could add a sound effect here, which would be a drum roll, because we were very dazzled by these findings. So the points where we could compare the two groups were baseline vent off 15 and 30 minutes. And as you can see, the green line represents the control arm. In the control arm, patients were not in distress at baseline, but rapidly accelerated to moderate to severe distress and stayed in distress until they died. In the intervention arm, and I can't explain why there were differences at baseline in the two arms. They should have been similar, and there's no reason in a random trial that they should be so different, but they were. So at baseline, in the intervention arm, patients were in moderate distress, and we know that patients, while ventilated, can still experience dyspnea. At ventilator off, they were comfortable at 15 and 30 minutes, and until death, they stayed comfortable with RDOS scores less than 3. You see our statistical findings to the right, a very strong, very effective with a moderately effective effect size, which we were extremely pleased about, particularly since we ended the study early with an uneven sample. The clinical significance is the patients had little distress in the intervention arm to moderate to severe distress in the control arm. Medication use, as we predicted, was going to vary, and it did. We used parenteral morphine equivalents and parenteral lorazepam equivalents for comparison purposes. You see in the control arm, a great deal more morphine was given compared to the intervention arm. And that might surprise you because I just showed that those patients were in more distress. Part of the explanation for that is there were patients in the usual care arm who had no distress, yet were medicated. And some were medicated with lots of medication in spite of having no distress. And lorazepam equivalents were also given more often in the control arm. And for those of you that work with critical care units, you know that benzodiazepines are the favorite medication for sedation. We also know, though, in the palliative care literature, understanding the dyspnea evidence, lorazepam is not useful as a primary medication. And in a secondary analysis of this study, we found that that was also the case. So the conclusions from this trial is this is the first intervention trial. Most of the previous studies, including the very large study by Roberts et al. In France, were not done targeting the patient's respiratory distress as the primary aim. And they were not trials testing comparing one approach to another approach. The Roberts study had more than 200 critical care units in the trial, and each unit used as a default either weaning or terminal extubation. And so they could make comparisons group-wise, but not head-to-head wise in a randomized controlled trial. Application of this nurse-led respiratory therapist supported algorithm ensures that the promise we make to families when we're sharing this decision to withdraw ventilation, and we promise that the patient will stay comfortable. So I'm confident that other sites who have already applied this algorithm are finding similar clinical results. So it ain't simply pulling the plug, and one size approach is not suitable for the kinds of patients that we undertake this with.
Thank you, Margaret. As I said before, I think that this trial is very important because we had the impression, because of the descriptive study, that the French descriptive study that you mentioned, that it was the same, right? That it made no difference what we choose, and in that sense, precisely, there was like no necessary, there was no need for a protocol. But this randomized control trial definitely show us that it's quite different of what we thought, and that it requires a level of expertise that palliative care clinicians are called to acquire during their, I guess, from now on.
Yeah, and in the Roberts trial, which was huge, and it was exciting when it first came out, and then when you dig deeply into that trial, they did find the patient's comfort was not their primary aim. It was a study of the families. They wanted to know if families 3 or 6 months after had different distress depending on which approach they got. And their finding was incidental that patients in the terminal extubation arm had more gasping than patients who were weaned. But they also didn't use a sensitive instrument to measure patient distress. They used the behavioral pain scale, which is not valid for measuring respiratory distress. So there was a number of limitations in using that trial to suggest an approach.
Precisely. I agree. I had some prepared questions and others that I just came up with them as I heard you. But I would like to hear Jessica and her takeaways of what you just shared with us. So please.
Yeah, Dr. Campbell, thank you so much, A, for doing this, and then B, for being sharing with us. Would you take us back a couple of years to when you were coming up with the RDOS and sort of, you know, I think so many of us think about symptoms that we see that we just don't feel like we have a good way to interpret that. And I know one of the distresses I hear from nursing staff is, I don't know what distress looks like. So can you sort of take us back a few years and just talk more about creating the RDOS? I know that's kind of earlier than this paper, but just how you decided what to land on and just how your experience played into that, and just walk us through that process a little bit.
Sure. Well, I prior to becoming a full-time academic, I was a full-time acute care, palliative care nurse practitioner. And in those early years, and we're going back a number of years now, in those early years, I was a master of recognizing when the patient was in respiratory distress and when they weren't. And so I would leave orders and I would go home overnight, and I'd come back the next day and I'd find the patient in distress and nothing was given overnight. And I would take the nurse and I'd say, look at all that distress. And they say, I'm not seeing what you're seeing. So what I needed to do was create an objective way that nurse to nurse, physician to therapist could see the same thing. And I was a PhD student at the time. So there was my PhD dissertation study. So I took a critical care unit and patients who were undergoing a spontaneous breathing trial, but were probably going to fail the breathing trial. They patients that were probably on the margin for not doing well, but they were going to try the spontaneous breathing trial anyway. And so I videotaped the patients. And I also had a capnograph oximeter attached to the patient so I could get continuous oxygen saturation and end-tidal carbon dioxide to continuous heart and respiratory rate. And then I put an accelerometer on their ankle so I could get restlessness. So for all the variables that now are in the RDOS, I obtained them through that study of viewing patients and then analyzing those results. And then there were several studies after I developed the first round of RDOS, several studies to test reliability, nurse to nurse reliability, scale reliability, and then validity, and then eventually cut points. So a lot of my research career was RDOS development and then using it as dependent measure in some of my subsequent studies, including this trial. But a lot of my research, because I was a bedside practitioner, a lot of my research questions came from evidence at the bedside or lack of translation. I knew what I was seeing, but I couldn't convince nurses until I did a study and published the study. And then nurses could take that evidence and translate it into bedside practice. So what I'm extremely proud about, and I'm going to brag a little bit here, in the US, there are more than 150 sites, both home hospice, inpatient care, nursing home care, using the RDOS in a palliative context. And 11 countries, and I mentioned at the beginning that I've got, I think, 7 or 8 translations. So people do recognize we do need an objective way when the patient can't self-report. So along with like the behavior pain scale, the pain ad scale that we use with dementia, this falls into that category of observation scales.
Well, thank you so much. It is not something that we use, but it's definitely something that, you know, whenever I'm filling out my orders, and you know, I always write, this is what dyspnea looks like, but now I'm going to add some of those other things in that I've not put in before, and then think about, can we put RDOS and Epic and kind of give something give some girth to what we're doing.
A year ago, I gave permission to the Epic platform to embed RDOS. So you might want to check with your IT people. If you're on Epic, you have access to RDOS through Epic. And it maybe you might need to have an update or whatever the technical things are to make it accessible. Now, if you're on Cerner, I can't help you there.
We have another question from Dr. Marta Jimena. Please, go ahead.
Thank you, Dr. Campbell, for this great explanation of your article, and for the RDOS. I really haven't used it, and I didn't know about it. I want to ask two things. First, if it's you said that it's like translated like to 6 or 7 different languages. You know, if it's translated to Spanish is the first one, and the second one is because we do have a next meeting with the ICU palliative care people, so it will be great to talk about this one, if they know the RDOS or not. And the second question is, what other type of circumstances or places do you know they are using the RDOS, or in what other type of situations they are using the RDOS that are not only the extubation that you have told us in this moment?
Yeah, the RDOS has been translated into Spanish. If you drop me an email, I can send you a Spanish version of the RDOS. And I think my email was in the slide. As far as settings where the RDOS, there are actually some sites now that are using the RDOS, not just in a palliative care context, because it doesn't have to be used just in that context. So for example, if the patient is going to undergo a spontaneous breathing trial, a patient who may survive the ICU, you can still track their responsiveness with the RDOS while they're in the spontaneous breathing trial. So it doesn't have to be, it was developed for palliative care, but it can be applied otherwise. Hospices are using it for those patients who are approaching the end of life and no longer able to give a self-report. So I'm aware of it being used across settings of care where patients don't have the ability to self-report, but might be in respiratory distress.
Thank you.
Great. There's another question in the chat by Andrea Paola. I'm going to read it out loud, Dr. Andrea Paola. She says, thanks, Dr. Campbell. Right now I'm in neuropeds, and I have to do a protocol for compassionate extubation in kids. And it's very, very difficult to find information. I only find a little protocol for some universities and an ACT guide. Why do you think this is feasible if extubation is done in children?
I do think the algorithm would apply across settings, across ages. However, the RDOS has not been validated in children, and especially in infants. I know that signs of respiratory distress are different. A colleague from the Ohio State University and I several years ago developed an infant RDOS, but subsequent reliability and validity testing has not been completed. As far as children older than a year, but younger than adolescents, I think developmentally there would need to be perhaps a toddler RDOS, since those distress behaviors differ from infants, and then perhaps a young child. And I'm estimating, but I would defer to a pediatrician, that a teenager has the same behaviors as an adult. So I think the RDOS could be A quick validation study could be done with adolescents, but it would have to require development of a scale for infants and small children. So that's a long answer to your simple question. Yes, it would apply, except the RDROS is only valid in adults.
I guess is a field that is still to be researched more, but it's definitely promising. Okay, I wanted to make you another question. The first thing is I hadn't disclosed why we invited Jessica McFarlane, and it's because she, as a neuropalliative care doctor, has faced several tough decisions when it comes to the ICU, precisely because of what to do with patients that may be extubated and have uh, um, a bad prognosis, but a prognosis for which you have also to wait until you get like the right answer, right? So it's complicated, and the extubation appears like a as a possible solution, right, or as an option at some point. But I would like you to walk us through, and you could, I mean, Jessica, please feel free to jump in, um, to also collaborate on answering this question, because I think it's something that's quite difficult, and it's like, how would it be from the beginning? Let's say that right now we have all these guidelines, clinical guidelines that focus on the communication with the patients, and when they are going to phase, or when a clinician is proposing an extubation. But now you have tell us the how of the extubation precisely. How would what you found would change the communication with the family? Who would be the one to do it? How would you how would you insert this information when talking to the family? Would you do it? I have no idea. How would you do it?
Well, if I don't think the communication approach to a family with the patient on a ventilator is going to be different. You're still going to communicate the patient's prognosis. You're still going to share the option for releasing them from the ventilator as part of their palliative care terminal process. And then when the family says, or if the family says, can you be sure you will keep them comfortable? That might be where you insert. There's a recent clinical trial that shows us objectively that we can keep the patient comfortable, and there's an approach that we will use with your family member that follows that science. I guess that's maybe what I would say. Families don't have experience with this usually. Usually it's a one-time and they're facing this kind of decision. And the questions families have asked me is, can you keep his breathing comfortable? And maybe a short answer would be yes. And maybe we don't need to trouble them with, well, there's evidence and we read this paper and blah, 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 blah. You know, that's yes and no are complete sentences. Can you keep his breathing comfortable? Yes, we can. And we will.
I understand Jessica agrees with you. Jessica, what has been your experience, and how would you navigate this equation with the information Margaret gives us or puts in the table?
Yeah, I think I I really like RDOS because it reminds us what to prepare families for. So, just one second. Sorry, I had a cough. Um, so one of the things I think that helps all of this go really smoothly is if families know what to expect. And in the neuro ICU, because consciousness is so decreased, and oftentimes people are really, really weak, we might not see the movement as much, but we might hear sounds that can be distressing. So I like to talk about, symptoms that we can't control, and then symptoms that maybe families need permission not to worry about, like snoring or changes in patterns. So that's what I try to prepare families for. what to watch for even before we take the ventilator away, so that they're not surprised by it. But then they also then know what to sort of be concerned about. So if they see something different, you know, we try to make sure that families ask questions. If you see someone breathing too fast, let us know, because we can help with that. You know, I try to coach families through that before we ever remove life support on brain injured patients, because it does look different, and can last much longer than someone that's dying from actually respiratory failure, rather than a neurologic injury that's just keeping them from protecting their airway.
Yeah, I agree with you. And sometimes families are at the bedside while we're doing this procedure. And I will say to the family, we're going to turn this down. We're going to do it gradually. I'm watching him continuously for distress. And here's how I know. He's laying quietly. His breathing isn't fast. He's not struggling. His chest muscles are relaxed. This is how I know he's comfortable. So you're giving them the same facts I'm looking for. So now they're watching and looking for the same thing. And you're correct with the neuro ICU patient who's only been intubated for airway protection. That's a different patient than the MICU patient who's in multiple organ system failure in terms of survivability. And this is one of the things we also found that I didn't share today. We found that the patients who have a neuro insult and are taken off the ventilator, as long as they have an intact brainstem, they might live 2 or 3 days, compared to the patient in multiple organ system failure who's going to die in minutes. And so you've got quite a range of who dies quickly. And that's also something families will ask about, because they need to plan their lives. Are they going to go home and feed the baby, or are they going to stay at the bedside? So I think where some of this evidence is informative, not just for us as clinicians, but for the families of the patient.
Amazing. Thank you very much for your guidance. Another question that was brought up by, we socialized the article with the IC team that I work with, or I had worked with, and one thing that I felt that they had an inquiry on was the infusions that the patient may already have, because if the patient is in ICU and is intubated, probably he or she has fentanyl or has ketamine or already has some kind of sedative or opioid, and they expressed they were a little bit distressed about the idea of giving an extra dose of opioids. They understand like the principle of double effect and all that, but they still thought that it may be too much, and that they had doubts on how to, let's say, get to the proportionate dose, right? So how did you manage the infusions? Did you replace the doses of morphine of the algorithm for the infusions? Did you keep the infusions? If you could give us a little bit of light on that matter.
Yeah, part of the algorithm suggests during the assessment stage. The assessment stage is the beginning, where we ascertain the patient's RAS score. Are they in respiratory distress while they're still being ventilated? And what infusions do they have, and are they still indicated? So for example, a patient has status epilepticus, and so they're on a lorazepam infusion. That infusion is probably going to continue. But that infusion isn't going to treat respiratory distress. It's going to control the status epilepticus. So that kind of clinical decision-making needs to be done with the team about the individual patient. I couldn't build it into the algorithm because of the unique patient characteristics. So if the patient is already on a morphine infusion, but still develops respiratory distress as we wean their ventilator, then you're going to bolus the patient. And that'd be an additive dose, but you don't bolus them if they're comfortable. So I think the concern your team might have is we don't want to hasten death, but we do want to treat distress, and using that objective measure will guide us. If the patient is not in distress, they don't get a bolus.
Amazing. Thank you. Thank you. Another question, and this is a little bit. I think it's something very important that maybe you highlighted in the presentation that you made, but for me, it's something that is a finding equally as important as the algorithm itself, is that all this work was done by nurses and led by nurses, right? And by the therapists, the respiratory therapists in the ICU. And I think it's very important because normally we would think that this type of measurements would be taken by a doctor, maybe by the ICU physician or somebody else. But in this case, we're nurses. So I guess that, well, apart from the training that you did with them, is something for them to be empowered, learn, and really take decisions in the moment the distress is happening, right? And I think this might be challenging because of the hierarchy that maybe some hospitals have, where these type of initiatives may be not accepted. So I also wanted to know, like, for you to tell us a little bit of how was this process on empowering nurses to do the extubation.
When I approached the 5 hospitals to get their buy-in that I could use them as one of my clinical trial sites, I practiced palliative care in the same Detroit community for more than 30 years. And I trained most of the fellows that eventually became intensivists. So, or became palliative medicine, so I knew people at every one of these sites. And so when I proposed them, I had the results from our pilot study. And the graph I showed you that showed the difference between the 2 groups, we had the same exact graph in our pilot study with a very small sample. So I was able to bring evidence to say this works. And then when I said, and I'm going to train your nurses and your therapists when we do the crossover, and the nurse will be in charge of the withdrawal with support from the therapist. And there was no pushback from the docs. No doc said, no, I insist, I'm staying at the bedside. When you think about it, the palliative care patient is part of your concern as the attending intensivist. But you've got 20 other patients or 30 other patients that are demanding your time. And if the nurse can lead this process, the families didn't push back about that. The attendings didn't push back about that. And the nurses, because it was the same nurses, once that site crossed over to the intervention, and I trained the nurses and the RTs, there was like a hallelujah, let us do this. Because they had some demoralized experiences of patients in distress that didn't get treated adequately. They had some demoralizing experiences of what appeared to them as hastening death. So the nurses were ready to own this in this country.
I think that's an amazing lesson. Before I continue with all of my questions, Jessica, I know that you also prepared some, so I'll let you go ahead.
Yeah, thank you. So I noticed that the graph that you showed us today included both the intervention and the control groups. But in the paper, I only saw the intervention graph. And I think when you show them side by side, it really kind of stands out to me. Did I just overlook that, or was there just kind of a limit?
No, there were 2 graphs in the paper. One that showed the control group, but the same graph that I showed you today. But I also had a second graph that just showed what happened with the patients that were in the weaning part of the intervention arm. So it wasn't the entire intervention arm, it was just the patients who were weaned, because I couldn't compare those to the usual care arm since the usual care arm wasn't weaned. So one of my graphs showed from baseline to vent off. I think there were 8 RDOS measures from baseline to vent off in the patients who were weaned. And all of those data points were below 3.
Okay.
And I didn't include that slide today. Juan said I could only have 15 minutes, so I didn't include that slide.
Gotcha. But that's important for us to think about, is that it's not the entire intervention, but the ones that were weaned.
Exactly right.
Okay. Because they might not have needed to be.
That's right.
Okay. Okay. Thank you. Thank you. That helps clarify that.
Sorry, my bad. We just had so many questions that we limit you to 15 minutes.
Sure.
Margaret, what can go wrong? I understand that it's not the algorithm itself, right? Because the randomized trial already proved that if it's well implemented, it can help, and that there's a difference, and that it should be implemented. And I'm eager to see the next clinical guidelines on palliative extubation incorporating the algorithm, because I think it's what has to be done. But I guess that one thing is what you do in a trial where you have precisely controlled, right, and real life. So from your experience, from what you see in the different sites, from like thinking in other settings, what do you think that, if not correctly implemented, could go wrong and will, well, not have the same results as the ones that you got?
Well, and I actually have experience with that with one of my sites. The pulmonary critical care docs did not like the weaning approach, which in detail was a stepwise PEEP, then adjust the FiO2 down, then change the patient to a synchronized IMV pressure support mode, and then wean the ventilation using that mode. And the pushback was, no, that's not a weaning mode. That's outdated. We don't use that anymore. And what they fail to remember is this is a different context patient. And the SIMV approach, instead of assist control, lets you, from the first change to that mode, see the patient's spontaneous tidal volume. With assist control, every time the patient initiates the breath, they get the preset tidal volume. In SIMV, the preset rate gives them the preset tidal volume, but their breaths in between are at their own tidal volume. So this is the earliest opportunity to capture an RDOS greater than 3 and medicate the patient while you're still ventilating them. And then you go down with the SIMV. So, long story short, that hospital, once the trial was finished, they humored me by following the algorithm precisely. And as soon as the trial was finished, they modified the algorithm so that once the patient was on room air, they put them immediately to CPAP 0, pressure support 5. There was no weaning of ventilation. They went immediately to what would be a spontaneous breathing trial. And the interesting thing I learned from people who were part of my clinical trial was they could not match the RDOS scores that I found following the algorithm in the order that we tested it. So modifying it might be something. And another thing that might happen is, because it's nurse-led and RT supported, if you have a shortage of RTs, and they liked doing terminal extubation because it was one and done. Go in the room, take the tube, turn the vent off, take the tube out, and leave. Go see other patients. With the patients that are weaned, they're at the bedside with the nurse because they're making the vent changes when the nurse says, we're ready for the next change. So the RTs also pushed back. They didn't want to spend that much time at the bedside. And that's a process that within the hospital I can't address. I'm there to do a trial. The thoughts were twofold, and I'm a former critical care nurse. I know that in some intensive care units, it's a mortal sin to touch the ventilator unless you're a respiratory therapist. So if you can't touch the vent unless you're an RT, then the RT has to stay at the bedside. If the RT can't stay at the bedside, then the nurse gets to touch the ventilator. So that's maybe a solution to that, was one of our problems.
Complicated. Completely a cultural change in the way that we take care of our patients. And well, you already like brought something else that we wanted to ask you, and it's how long does it take? Because like there's not a good sense of how long can this take.
Yeah, it took, I'm trying to remember what we reported. It's either 18 minutes plus minus 27, or it's 20, yeah, it must have been 18 minutes, on average 20 minutes. But there are some patients, high FiO2, high ventilator demands, high use of the ventilator, that are going to take longer, because with each incremental change, there is a pause to re-medicate the patient before making a further reduction. So there are an occasional patient, and you will know who those patients are at the time of making the decision, because they're the ones with the highest demand. On the other hand, some of those very high demand patients, like ARDS, for example, die before the vent is completely turned off. And that was something that caused some issues with my study teams, was like, well, they're supposed to die after we turn the vent off. So you just let them talk that out, and then they see the common sense of the patient's going to die when they're supposed to die. So, you know, training staff was was also challenging, because all these kinds of questions that you're asking came up with the staff as well. Well, what do we do if? So I'm lucky that I came to this study with a long experience in adult critical care, so that I could problem solve how to make this work.
Yes, completely. I think that's a big part of everything that you have done, and well, the trial is like a recognition of your experience, and also like those friendships and that mentorship that you made throughout the years. We're getting to the end of our session, but before we end, I wanted to give one more time the word to Jessica, so you could also ask Margaret or comment on anything else that just of what she has said.
I think my one question would be for people that are thinking about capturing something that they're seeing, but haven't been able to sort of convince other people. What word of advice would you give to someone that's thinking about maybe developing a scale and going forward with it?
You mean like a pediatric RDOS?
Yeah, or for somebody in a neuro ICU, or just any scale that you know, that we see in palliative care that would help improve symptom management for somebody else.
Yeah, well, scale development is a whole body of science and approaches to how to develop a scale, separate from doing a clinical trial. And I think that aligning with a scientist who has those kinds of psychometric skills would be a way for the clinician to say, these are what we need to look at, and then for an academic to refine, how are we going to validate this? How are we going to make it an effective, reliable instrument? So I think that's where a partnership comes in. And I don't think that an academic can do this without the clinician, because otherwise it has to make sense. It has to be useful at the bedside. And we clinicians, I was a clinician scientist, so I could do that. But had I only been an academic and these things would have been theoretical, I wouldn't have gotten very far, because clinicians would have said, no, it doesn't work. It won't work.
So it sounds like that's a really good area for partnership as we're looking to find more and more evidence to bring into the practice of palliative care.
Yeah, and especially since you're at an academic medical center, you have those scientists to find at your university. Did you know Rick Zimmerman? He was at University of Kentucky before he came to Wayne State.
Ooh, I don't think I know that last name. I've been here about 6 years.
Yeah, he left Kentucky about that same time.
About that same time. Yeah, it doesn't sound familiar to me. We probably just ships in the night.
Margaret, one last question before we go, and I'm not sure if you want and if you're able to, but I think that all of us want to know, what are your next steps? What is the next trial? What is the next idea? What would you like to do next? I know that, well, maybe you have a lot of other plans regarding other things in your life. What would you like to do, or what would you like to see others like build up with this last algorithm that you just published?
Well, I retired 18 months ago. And for me, every day is Saturday. And so what I would like to do next is I would pick and choose opportunities to be a consultant on someone else's study. So for example, if somebody's going to develop an infant RDOS or a toddler RDOS or a young adult RDOS, I would be able to guide them on how to do a psychometric study of a new instrument. I think that's needed. And we heard that from one of your colleagues on this call, that what do we do in peds? You know, I think that's the next frontier where palliative care needs to help guide translating adult work into pediatric work. But I'm not going to write another grant. I'm not going to be a PI on anything else, because every day is Saturday.
I'm only happy to hear that. I think that it's difficult to call that decision, but I mean, every one of us owe us that time, and to get to say that every day is a Saturday and enjoy other things in life. And well, I just want to thank you for being here, for taking the time to make the presentations, share us your findings, also answering all of our questions, being so kind and open. And I hope that I'm sure that we're going to see that a lot of other evidence is going to be built up with what you just shared with us today.